Good morning, and thank you for the attention to this topic that I care very much about. My name is Teresa Kim. I'm a surgical oncologist at the University of Washington and Seattle Cancer Care Alliance. And today I want to talk about how to integrate surgery into multimodal management of sarcoma, basically some updates in some historical traditional management and evolving paradigms. I have no disclosures. Specific objectives for the talk today will be to, most importantly, identify clinical scenarios that are important for a surgical consultation, and then secondarily to define resectability and how we surgeons think about it, both in terms of anatomy and then tumor biology, and third, to list different neoadjuvant and adjuvant approaches to sarcoma management and the evidence or lack thereof to support that management. In terms of the general paradigm, I think for all cancers, there's a very basic set of steps that help us diagnose and manage cancers in terms of first naming the tumor, getting a tissue diagnosis, then staging it, and finally determining a treatment appropriate for that tissue diagnosis and stage. In terms of sarcoma and the role of surgery in sarcoma management, there's a few different scenarios that are relevant, including in the naming stage, diagnostic biopsy, and then in the terms of treatment, things management related to how advanced or not it is, as we can see here. We'll go into each of these scenarios in a little more detail. First with primary localized sarcoma that's resectable, where surgery is the only potential curative treatment. And then secondly, with primary localized sarcoma that's either high risk because of anatomy or tumor biology, where we'd like to add on different treatments to surgery. And then finally, in terms of recurrent disease that's either resectable or unresectable disease that's either metastatic or locally advanced, where surgery is more of a palliative than a curative treatment. In terms of diagnostic biopsy, the main change actually in sarcoma diagnosis has been that there's been a big move to core needle biopsies that are done percutaneously by the interventional radiologists, replacing surgical either excisional or incisional biopsies. There was a question about whether this was accurate or not, or prone to sampling error, but in several series from about 10-15 years ago, they have found that this is actually more than 80% accurate at both answering the question, is this mass malignant or benign? And if it is malignant, is it a sarcoma of high grade or low grade? And so you can see, especially with the very basic question of malignant or benign, accuracy in this series of core needle biopsies was over 90%. And so this and other experiences in big sarcoma centers has led to an adoption of percutaneous core needle biopsy as the acceptable first-line technique for tissue diagnosis. If a core needle biopsy is either not possible due to inability to safely obtain a window to the mass, or if it comes back indeterminate pathology, those are situations in which a surgical biopsy to follow that up might be helpful. And just as a brief aside, the AJCC staging system from the 7th edition in 2010 was primarily based on the standard tumor node metastasis paradigm that applies to a lot of cancers, but also importantly includes tumor grade. So basically a 3-part score based on differentiation of the tumor cells, number of mitoses, and then amount of necrosis in the tumor. This sarcoma grade is quite important to predicting sarcoma biology, recurrence, risk, outcomes, and is a little bit different from other types of carcinomas, epithelial cancers. What you can see here is that there's a certain distribution of stages 1 through 4 based on the TNM and grade. Starting in January, there's actually going to be an update of the AJCC staging where the breakdown in size is a little bit more stratified, from less than 5 to 10, and then over 10 centimeters. And then in the grade combining grade 2 and grade 3 into high grade versus grade 1, which is low grade. But you can see that generally the stages basically, again, similar to the old staging system, group the low stage localized T tumors that do not have nodal or distant metastases into stage 1, stage 2, divided by grade. And then in stage 3, start looking at high grade tumors that are localized versus tumors that have nodal mets. And then in stage 4, tumors that have distant metastases, most of which are high T stage and high grade. So to get back to our paradigm of treating sarcoma, the different scenarios that involve surgery for treatment are now what we're going to delve into. The first scenario is the most obvious one, basically with a localized mass that on the prior workup has a tissue diagnosis of sarcoma and is without evidence of distant disease, then radical resection for curative intent is the defined treatment. If you look in the NCCN guidelines, these guidelines for sarcoma particularly are very complicated with a lot of different options. And I think on the one hand, these allow for different choices to be made by expert multidisciplinary centers. On the other hand, they may be very confusing to refer to for reference if you're not in the field. But the simplified management to glean from these, at least these tumors that fall into this scenario of resectable localized sarcomas, is surgery. When we say radical resection, what we mean is taking out the entire tumor on block with a rim of normal tissue to try to maximize the chance of having negative microscopic margins and ultimately to maximize the chance of avoiding recurrence in the future. And so adequate oncologic margins have not been studied in a randomized controlled trial like other tumor types, but generally involve a 1 to 2 centimeter margin if that's possible, or in the case of the intra-abdominal retroperitoneal tumors, at least having an intact fascial plane. And so these pictures are just a couple of examples of what we would consider a resectable tumor. So even though this was a large sarcoma arising from the retroperitoneum here on axial and coronal views, this was not actually found to be invading any surrounding structures such as the colon or the iliac vessels. And so in its encapsulated form is actually considered to be resectable and was able to be removed surgically without any additional organ resection. When we start delving into some of these localized sarcomas, they can be in locations that do have high-risk anatomy. And so this is our second scenario where we start thinking about with high-risk anatomy, being able to obtain those negative margins and intact resection and the risk of recurrence if we have to come close on one of those margins. In these cases, again, the NCCN guidelines are very complicated, but basically allow and encourage consideration of radiation in either the preoperative or the postoperative setting, ultimately to try to decrease local recurrence. And so when we say high-risk anatomy, this can mean two things primarily. One, large size, which has been correlated with higher risk of recurrence, especially in extremity tumors. And so you can see here a 16 centimeter tumor of the lower extremity abutting the knee joint. And then in the intraperitoneal or retroperitoneal intra-abdominal scenario, if there are tumors that are invading or appear to be invading other structures on the preoperative CAT scan, such as the bladder in this case, the external iliac vessels, or other critical structures. So in any of these cases, we have the option to include radiation in the treatment paradigm with surgery. I think as a pause, anytime we're thinking about neoadjuvant or adjuvant therapy for any kind of cancer that looks surgically resectable, and as a side question, do you refer this patient to just the surgeon or also the medical or radiation oncologist? There's 4 really basic questions that help address that issue. One is trying to quantify the risk of local versus distant recurrence. 2, quantifying what the absolute risk reduction is with the therapy you're considering, such as radiation. 3, what the cost or toxicity is to the patient, particularly in terms of side effects. And 4, if you don't offer that adjuvant therapy and the tumor recurs, how difficult is it going to be to treat that recurrence? What are the salvage options? And so in thinking about these sarcomas, like you just saw in the imaging, that are close to critical structures or have a large size, basically the high-risk anatomy ones, we want to estimate what the risk of local recurrence is. And this we can get from information from some randomized trials, the few in sarcoma, and some nomograms that have been published. And then actually look to those trials to see what the absolute risk reduction of local recurrence is with radiation, what the side effects of radiation were in the pre versus post-operative setting, and then what the salvage options are. And in the extremity, salvage is sometimes quite simple to do with another surgical radical resection or re-excision. And so this is an important fallback treatment that we consider in the whole big picture. And so just in terms of local recurrence, what's pictured up here is 2 different published nomograms that apply to extremity surgery on the left and then retroperitoneal surgery on the right that help us answer that first question of actually putting a number to the question of what is the chance of this patient's tumor recurring. These nomograms are based on retrospective series from multiple centers that try to basically pull out factors or clinical or pathologic variables that are associated with local recurrence, and then combining them into a multivariable model that allows you basically to choose the different categorization of each of these variables, apply a score to your specific patient, and get a slightly more accurate or specific estimation of local recurrence for your patient, rather than looking at the average median local recurrence-free survival in a large series that has heterogeneous patients. And so looking on the left nomogram here, the major factors for extremity sarcomas that predict local recurrence after surgery are age, where high age has a higher risk, size greater than 5 centimeters has a higher risk, and then important pathologic variables, including close or positive margin, so R1 or R2, or a less than 1 millimeter margin, high grade, so poorly differentiated, lots of necrosis or mitoses, and then histologies that are not the low-grade atypical lipomatous tumor. And so things like dedifferentiated liposarcoma, pleomorphic liposarcoma, leiomyosarcoma, and others all have an impact on risk of recurrence. And so we can imagine from that tumor that we saw in the picture next to the knee that was 16 centimeters, if that person was over 50 and had this large tumor where we are anticipating that it's going to be a close margin, all of a sudden that score really adds up to a high score that's estimating a 20 to 30% local recurrence rate at 3 and 5 years, and really above a somewhat arbitrary threshold where we would want to consider an adjuvant treatment like radiation to try to decrease that risk. In the retroperitoneum, this has not been as clearly studied, but a group from Europe made a nomogram for trying to predict recurrence-free survival in retroperitoneal sarcomas after surgery. And again, you see a theme that size, at least up to 30 centimeters, higher grade, and then different histologic subtypes predict the chance of recurrence in a way that if a high risk of, or a low recurrence-free survival is predicted, again, we may consider adjuvant treatments. The second question about what the absolute risk reduction is with radiation has been well studied in the extremity sarcomas and not as well studied in the retroperitoneal sarcomas. So this is the one question that has good quality data to support adjuvant radiation, basically in high-risk extremity sarcomas. And so I just want to go through a couple of the randomized controlled trials that support that type of treatment. The first trial was out of Memorial Sloan Kettering Cancer Center. This was a phase 3 randomized controlled trial of extremity soft tissue sarcoma that was treated with limb-sparing surgery or radical resection, randomized to either brachytherapy radiation or no radiation after surgery. And what they found was that the adjuvant brachytherapy radiation decreased local recurrence and improved local recurrence-free survival by more than 10%. And so basically, you can see in the no radiation survival curve, local recurrence-free survival is lower than the patients that did receive brachytherapy radiation. And what they found was that in a subgroup analysis, these patients with the benefit from postoperative radiation were primarily high-grade patients, where in the subgroup of low-grade sarcomas, they did not have a difference between local recurrence with radiation or without radiation. A similar trial done by the NCI took the same category of patients, extremity soft tissue sarcoma, status post the radical resection, and instead of brachytherapy, randomized them to post-op external beam radiation versus no radiation in the postoperative setting again. And what they found, again, at the 5-year time point was actually an even more dramatic improvement in local recurrence-free survival from 70% in the no radiation group to nearly 100% in the radiation group. And this benefit actually held for both low-grade and high-grade sarcoma patients. And so the combination of these two trials really set the standard of care to offer radiation, at least for high-risk sarcomas in terms of large size, greater than at least 5 centimeters, and high-grade or potentially high and low-grade tumors. The question then arose of whether to time this radiation preoperatively or postoperatively. So a trial, another phase 3 randomized controlled trial out of the Canadian Cancer Group, took the same category patients, extremity soft tissue sarcoma, after radical resection, and or before or after radical resection, basically randomized patients to preoperative radiation with 50 gray or postoperative radiation with 66 gray. And what they found, importantly, was 2 categories of findings. One was that all the oncologic outcomes in terms of local recurrence and survival were no different between pre- and post-operative radiation. And again, local recurrence, similar to the NCI trial, was between 90 and 100% local recurrence-free survival. However, what they did find was that the difference between pre- and post-operative radiation was that there were double the wound complications in the post-operative radiation group. Compared with the pre-op radiation group, 35 versus 17%, and particularly in the lower extremity sarcoma patients. And so this trial helps us in multidisciplinary discussions determine whether to opt for preoperative versus postoperative radiation. If we're concerned about wound healing, particularly if it's a thigh or a leg sarcoma, we may opt for postoperative radiation. If it's an upper extremity sarcoma, we may opt for preoperative radiation. The other long-term follow-up of these trials have seen, unfortunately, a trend in increased issues with joint fibrosis and tissue fibrosis in the preoperative patient group. And so the take-home from the long-term analysis of this trial is that there are side effects that come with both preoperative and postoperative radiation. We have to weigh the risks and benefits, with the location of the tumor being one of the primary elements to consider. In terms of retroperitoneal sarcomas, the data is a lot sparser compared with the high-quality randomized phase 3 data that we just saw for extremity sarcomas in terms of radiation. And this remains actually a very controversial subject in the field of sarcoma, whether radiation, in this case, in the retroperitoneum, decreases local recurrence at all. There are several prospective uncontrolled studies, one out of MD Anderson and Canada, and then another out of MGH, that have looked at different types of radiation, either external beam, IMRT, which is a more targeted type of radiation, or even adding intra-op or proton radiation in conjunction with radical resection of retroperitoneal sarcoma, and have found very high local recurrence-free survival rates of 60 to 80% that are maybe higher than historical controls, but these data are hard to interpret without a prospective controlled study. So one trial that sought to answer this question started in the United States but closed early due to poor accrual. And there's one current trial going on in Europe, or run by the EORTC, called the STRASS trial, which does seek to answer this question. For retroperitoneal sarcoma, does preoperative radiation decrease local recurrence? This trial has actually just finished accruing, but the data to come out of this trial probably won't be available until about a year from now. And so we're left with these uncontrolled prospective studies and then retrospective series, basically to incorporate into our multidisciplinary discussion about whether radiation is appropriate for a particular retroperitoneal sarcoma patient coming through our clinic. And I would say that this is one of the examples of why it's very important for a sarcoma patient to be seen in this kind of high volume center in the multidisciplinary setting, because these decisions are very nuanced upon the specific characteristics of the patient and the tumor, in lieu of phase 3 data that we have. In terms of retrospective series, there are several series, one from Memorial Sloan Kettering and MGH, trying to compare patients that received radiation versus not, that did see an association with higher local recurrence-free survival of 91% in the radiated cohort versus the 65% local recurrence-free survival in the non-radiated cohort. Unfortunately, this is a retrospective comparison, basically between one institution that provided a lot of radiation and another that did not, and it's hard to know if there are confounders in that related to the institution or patient selection. And we have similar findings of potentially improved survival in a large NCDB review of sarcoma patients treated with surgery and radiation. But again, it's hard to understand without a prospective controlled study whether this represents a benefit or biases from the retrospective studies. And so I would say the take-home for radiation for retroperitoneal sarcoma is that it's still a discussion, whereas in extremity sarcoma, it's a proven benefit for local recurrence control. When we start talking not about necessarily high-risk anatomy, but high-risk biology, that's when we start worrying about distant recurrence or metastatic risk. And rather than radiation, which helps with local control, it's important to consider chemotherapy, which may help with distant control or distant metastatic control. And so, again, looking at the NCCN guidelines, when we think about high grade, which often is a reflection of high-risk biology, again, there are many different options within the combination of surgery, chemotherapy, and radiation to consider, basically, in the treatment of these sarcomas. But in addition to high grade, when we think of high risk biology, there are probably more than 100 histologic subtypes of sarcoma that have currently been described, and it seems to be increasing every iteration of the review of sarcomas. But there are some histologies that are known to be high grade and predisposed to distant metastatic spread. And some of these histologies are pictured here. These are often poorly differentiated and have significant mitoses and necrosis within them, including the myxoid round cell liposarcoma and pleomorphic liposarcoma. These are much different from the well-differentiated liposarcoma or the predominantly fatty tumors that are low risk. These are very much higher risk histologies. And then there are histologies such as Ewing sarcoma and angiosarcoma, which again have been found to be very, very high risk for metastatic disease. These histologies do have varying sensitivities to chemotherapy as well. And basically the risk of grade in biology and the sensitivity to the available chemotherapies are what we consider in deciding for a localized tumor, for example, a pleomorphic liposarcoma in the leg with a high-grade large size. Do we think about chemotherapy for that patient, even though there's no metastatic disease right now, with the theoretical concern that there's micrometastatic disease that's already present? And so looking back at our 4 questions about just how to decide about neoadjuvant or adjuvant chemotherapy, we really want to think about what is the risk of distant recurrence. Again, looking to published data and nomograms to estimate that. And then what is the risk reduction that chemotherapy provides, looking at the available trials. What is the cost or toxicity? Particularly with chemotherapy, there's a significant risk of side effects. And then what are the salvage options? If we don't give chemotherapy and or the patient recurs, for example, with a lung metastasis, what are the salvage options there? And there are several, including metastasectomy and radiation. And so that provides another element of the discussion. In terms of predicting distant recurrence, there are large retrospective series out of high-volume centers such as Memorial Sloan Kettering that have looked at basically this question by histologic subtype, with the most common of the 100-plus subtypes pictured here. In terms of the retroperitoneal sarcomas, they're often either well-differentiated or dedifferentiated liposarcoma, or the smooth muscle tumor, leiomyosarcoma, or several other subtypes such as solitary fibrous tumor or the malignant peripheral nerve sheath tumor. And what we see for distant recurrence is that the high-grade leiomyosarcomas and then the dedifferentiated liposarcomas have a certain risk of metastatic disease, almost 40 to 50% for leiomyosarcoma, and between 20 and 30% for the dedifferentiated liposarcoma, that are much higher than the another histologic subtype, such as the well-differentiated liposarcoma. So this estimate of risk of distant recurrence really, I think, speaks to how important it is to have the appropriate histology on the diagnosis, the pathologic diagnosis. In terms of trying to predict what the benefit of or the risk reduction of chemotherapy is, there's basically one old chemotherapy, adriamycin or doxorubicin, that's been studied the most in soft tissue sarcoma and has provided the greatest benefit in the metastatic setting, sometimes combined with ifosfamide or that AI chemotherapy regimen. A lot of these studies ultimately have been extrapolated from the metastatic setting to the local adjuvant or neoadjuvant setting, but have not had tremendous clear effects on either survival or local recurrence. And so a meta-analysis done in 2008 looked at 18 of these trials, a handful of which included the double chemotherapy, adriamycin and ifosfamide, and then saw that basically in terms of survival, which is pictured here, there was a very small benefit of adjuvant adriamycin ifosfamide chemo in terms of overall survival. When they tried to quantify the absolute risk reduction, what they saw was that there was a 9% reduction in distant recurrence, a 6% improvement in overall survival, and a 4% reduction in local recurrence. And as you can see, different trials are basically on one side or the other favoring chemotherapy or not. And so this data is potential data in support of considering adjuvant or neoadjuvant adriamycin ifosfamide chemotherapy, but is limited and does not show a large benefit. And as an aside, they did not specifically look at this, but do not speak to the toxicities associated with especially doublet chemotherapy in terms of cardiac toxicity, especially with adriamycin, and kidney toxicity with ifosfamide. And so this meta-analysis was followed up by yet another randomized controlled trial from Europe looking at the doublet chemotherapy in the adjuvant setting. And they actually did not see benefit. It was a negative trial for chemotherapy in terms of either survival or local recurrence. There's one final trial that just came out looking at chemotherapy in the neoadjuvant setting for extremity soft tissue sarcomas that were of high risk, so high grade, large size greater than 5 centimeters. These patients were actually randomized to neoadjuvant chemotherapy with the standard adriamycin ifosfamide, or with not a control arm per se, but histologic specific chemotherapy. So different types of chemotherapy rather than AI for different histologies such as leiomyosarcoma, which has been shown to respond to gemcitabine and docetaxel, and other histologies basically going along the different list here. What they had predicted or hypothesized was that the histologic specific neoadjuvant chemo would have a greater benefit than standard AI chemo. And what they found actually was the opposite, that disease-free survival was actually better in the standard chemotherapy AI arm, adriamycin ifosfamide, and that this very carefully laid out histologic specific chemo in the control arm basically did worse in terms of both distant disease-free survival and overall survival. And so what some have interpreted from this study is that this is a sign and evidence that neoadjuvant adriamycin ifosfamide actually does improve overall survival in these high-risk extremity soft tissue sarcomas. In lines with the meta-analysis that we had looked at before, but actually with a much more dramatic improvement, over 20%. Other folks will interpret this data basically that this was not a true control arm, and that it's hard to apply this it's hard to interpret this in the setting of trying to decide whether to offer somebody neoadjuvant adriamycin ifosfamide chemotherapy or not, because these patients on the histo-specific chemo arm may have done worse than somebody just on placebo control, basically surgery alone without neoadjuvant chemo. So again, unfortunately, this is an area of controversy in the field, and again, often comes to a multidisciplinary discussion and evaluation at a high-volume sarcoma center to really make that nuanced decision. There may be further trials in the future that clarify this question. And as we've been learning with sarcoma studies, the more that we're able to answer a question to a single histology, the closer we are to, I think, getting an answer about what the most appropriate treatment is. With 100 plus different histologic subtypes, there are going to be different categories of sarcomas that probably will benefit from neoadjuvant or adjuvant chemo or radiation in conjunction with surgery, and we haven't fully clarified that yet. If we take a step back and go back to our treatment paradigm and think not of primary sarcoma, but recurrent sarcoma, it is important to know that not all recurrent disease is unresectable, or that basically if a sarcoma patient presents with recurrent disease, it's important, again, for multidisciplinary evaluation to see, one, is this recurrence unifocal or multifocal? And two, should surgery be part of the combination treatment that's applicable to this patient in the recurrent setting? The other important thing to know is that this whole treatment discussion for a recurrent patient is more along the lines of disease control rather than curative intent treatment. Because once a sarcoma recurs, the risk of a subsequent recurrence is very much higher, and the risk of sarcoma-related death is higher, and cure is unlikely at that point. In terms of that question about deciding, is a local recurrence resectable still? These questions depend a lot on tumor biology. And so one of the things that this series from Memorial found was that, particularly for retroperitoneal sarcomas, there is a benefit, or not a benefit, I should say, but a surgical resection of a recurrence was associated with better outcomes, better survival, but that it was only for a subset of these recurrent sarcomas. And what they found was that if the local recurrence growth rate was high, beyond about 1 centimeter a month from the time of definitive treatment to the time of recurrence, these patients actually did quite poorly with low disease-specific survival, regardless of resection or not. And so pictured on this curve here was basically in this curve, slow-growing local recurrences, less than 1 centimeter a month, that were resected, basically had a higher disease-specific survival out to 5 and actually 10 years, whereas patients that either did not have a surgical resection or had a very quickly growing recurrence, greater than 1 centimeter a month, they all did poorly, whether or not they had surgery. The way that they calculated this local recurrence growth rate was basically taking the diameter of the tumor at the diagnosis of recurrence, at the largest diameter in centimeters, and then divided it by the number of months that had traversed from the original treatment. And so this is a rough rule that we are able to use in looking at a recurrent patient and trying to decide if surgery would actually help or not. And this is helping us take into account biology in addition to anatomic considerations about if it's involving critical structures, etc. In terms of recurrence in the multifocal setting, again, sarcoma is an interesting disease because multifocal or metastatic disease is not necessarily a contraindication to surgery. This is one of the disease subtypes in which metastasectomy or surgical resection of a metastasis actually can sometimes be associated with long-term survival. This is along a vaguely similar paradigm to colorectal liver metastases, again, where in a specific selected situation of oligometastatic disease, so disease localized to one organ, for example, or one part of one organ, that these patients might have a more latent biology where surgical resection of metastases may help. This is in the opposite of other types of tumors, such as pancreatic adenocarcinoma, where metastatic disease is so closely linked to poor survival that surgical resection is not considered. And so it is important when we're considering surgery for metastatic patients, that we select these patients very carefully. And so in lack, again, of prospective randomized controlled data, we looked to large retrospective series to figure out, are there clinical or pathologic variables that can help us select which patients we think will potentially have the best outcome from this surgical resection. And so the Memorial Group looked at a large series of sarcoma patients with lung metastases that underwent metastasectomy, and then looked into see what variables predicted better survival. And so what they found was that there are certain variables that are associated with overall survival in this type of patient, including histology, leiomyosarcoma particularly. These patients are prone to metastasis, as we saw before, but do have a better outcome than other histologies, if we look here, in terms of survival after metastasectomy. Whereas comparing this to the pleomorphic or malignant fibrous histiocytoma patients, these patients really did not had the worst survival after a lung resection, and may not be the best to consider for pulmonary metastasectomy. In terms of other variables, small size, longer disease-free interval, basically between the primary tumor and the diagnosis of the metastasis, and a solitary tumor, all were associated with better outcome, as was the minimally invasive resection with VAT surgery. And so to take this to a specific example, if a retroperitoneal leiomyosarcoma patient develops a lung metastasis, maybe too small lung metastasis in the left lower lobe of the lung 5 years after the original treatment of her primary tumor, that patient actually, we would expect to have a good outcome after pulmonary metastasectomy, and would consider, even if it's 2 nodules in the lung, not a solitary met. On the other hand, if a patient presents with a leiomyosarcoma in the retroperitoneum, or let's say a pleomorphic sarcoma in the retroperitoneum or the extremity, and a synchronous metastasis, and actually multiple metastases in the lung, this patient really has no disease-free interval, and multifocal disease, and a biology which speaks to the fact that they need systemic treatment much more than a local treatment, such as surgery. And so finally, thinking not about recurrent or primary resectable sarcomas, but unresectable sarcomas, I want to speak about basically the anatomic and biologic factors that preclude surgery resection, and the role of surgery not so much for curative intent, but for disease control or palliation. In the NCCN guidelines, this category basically of patients that have resectable localized sarcoma, but with adverse functional outcomes, for example, in the extremity, or unresectable disease. And so for locally advanced extremity soft tissue sarcoma that is wrapped around the critical neurovascular bundle in the leg, for example, the femoral vessels, or the nerves, where limb-sparing surgery really is not possible, there is always the option of amputation, which historically was the treatment for all extremity sarcomas, and now is a fallback basically for these really locally advanced extremity sarcomas. In Europe, there is a practice of isolated limb perfusion, where they perfuse heated chemotherapy with melphalan and TNF-alpha into the limb with the sarcoma, and ultimately try to avoid the need for amputation. They have had about a described 80% limb salvage rate for these previously unresectable sarcomas, but unfortunately this technique is not available in the United States because the TNF-alpha is very toxic and not FDA approved. And so there may be trials starting in the future trying to apply this technique with different agents to sarcoma patients here in the United States, but those do not exist yet. And then there is always the option before amputation of trying chemotherapy, radiation, or trial agents to see if there's sufficient shrinkage of a tumor to avoid amputation. But again, amputation is always the fallback option, which does potentially offer cure for this patient if it's localized disease in the extremity. In the situation for locally advanced retroperitoneal sarcoma, basically with involvement of critical structures that are too high risk to resect. This, for example, could be encasement of the abdominal aorta or the celiac axis, or the proximal SMA off the aorta. These are structures where resection technically may be possible, but the morbidity with the entire sarcoma resection is high enough that this would preclude a safe surgery. In these cases, again, chemotherapy or radiation can be given in an attempt to downstage the tumor, or consideration of trial agents. This is not always successful, but something that, again, is important to discuss in the multidisciplinary setting to try to offer the patients as much as possible. But those are basically the unresectable patients due to anatomy concerns. There's also unresectable patients because of their tumor biology, and again, as we were speaking about in the recurrent tumor category, these are patients basically with widespread disease, so multifocal metastatic disease, particularly if it is presenting synchronously or after a very short disease-free interval, less than a year, for example. In this case, for example, in multifocal lung metastases, multifocal regional nodal metastases, surgery is not necessarily going to be the most effective treatment for what is systemic disease, and chemotherapy is the first-line standard of care. If systemic chemotherapy is not effective and progression of disease occurs, there is a set of options available, not so much for disease control, but palliation in terms of palliative radiation, and sometimes palliative surgery if a particular tumor is causing either pain or ulceration in the extremity or small bowel obstruction in the abdomen. Sometimes a limited resection for palliative intent can be considered. There are additionally many new agents coming down the line in terms of systemic treatments that may be possible for patients, especially in the future, as we, I think, explore more the role of targeted molecular therapies, such as the tyrosine kinase inhibitors and other chemotherapies that have been recently approved in the metastatic setting, such as trabectedin, eribulin, and now olaratumab, which is a PDGFRA inhibiting antibody, as well as the newest category of treatments that a lot of oncologists are excited about right now, immunotherapy, specifically first with checkpoint blocking antibodies that activate T cells. And so all of these different trial agents are now in the process of being tested in combination with traditional treatments that we've gone over to assess first safety and then efficacy. And so our hope is that these will change treatment paradigms down the line. But just to review, for the current state of treatment of sarcoma, the important things are to remember that in the first stages of naming and staging the disease, surgery is not actually as useful anymore, and core needle biopsy is actually the standard, most appropriate way to obtain tissue diagnosis, unless it is not possible, in which case you can always call your surgical colleagues. And then in terms of treatment, that surgery actually plays a role in many different categories of disease, potentially offering cure for localized resectable sarcoma in either the extremity or the retroperitoneum intra-abdominal location, and that surgery plus radiation should be considered for localized sarcomas with high-risk anatomy, large size or abutment of critical structures like the vessels, nerves, and joints, and that alternatively radical resection with chemotherapy should be considered for localized sarcomas that have either high grade or high risk histologic subtype that we had gone over previously. and that when we get into more complex disease situations, such as recurrent disease, sometimes surgery can help with disease control, particularly with a favorable biology, such as slow growth rate and unifocal or isolated foci of disease. Whereas unresectable tumors, either because of their anatomy or their biology, are tumors that should really be considered first for chemotherapy or systemic treatment, and surgery for palliation or disease control. And so this is basically the objectives that we sought out to answer, and I think most importantly, the take-home from any type of sarcoma-related question or strange mass, basically on presentation, is that it's important to obtain good imaging and tissue diagnosis, and really to get that patient to a multidisciplinary center with surgical oncology, medical oncology, radiation oncology, pathology, radiology, who all together can assess the situation and lay out the best type of treatment plan, sometimes based on randomized controlled trial evidence, and sometimes really based on limited data and the experience of that sarcoma center. And I'd just like to thank the sarcoma team here, and I welcome any referrals at any time. Thank you.